Okay, perfect. So my name is Julia HEWS-GIRARD. I am, as you can see there, I'm affiliated with the Bleeding Disorders Clinic here in Calgary. I'm the Adult Bleeding Disorders Clinic. And I'm going to be talking today about bleeding of unknown cause. I have no disclosures, and everybody who shared their experiences with me for the case study and for the quotes did so with consent, and I'm very thankful to them for their participation. So we will start with a bit of a case study. So this is Jane. She's female, 30 years old, has a history of endometriosis and skin cancer, has had wisdom teeth removal and tonsillectomy and menorrhagia. Medications are there, so NSAIDs and Percocet PRN are as needed, and was referred to the clinic due to menorrhagia since menarche, abnormal and significant bleeding post-procedures, unusual bruising, see a postpartum hemorrhage, and abnormal bleeding from minor wounds. And both of her children have abnormal mucosal bleeding. When she came to the clinic, she had a normal physical exam. You can see the labs there, normal von Willebrand levels ×3, prolonged closure ×1, some normal coagulation tests, normal CBC, normal everything else. Bleeding score though was 16 and her Baton score was 2. So as far as rare disorders go, bleeding of unknown cause, or bleeding not yet diagnosed as it's referred to sometimes, is relatively common. And while there are no standard diagnostic criteria for bleeding of unknown cause, it is defined by the presence of an increased bleeding score and a normal diagnostic or laboratory workup. The true prevalence of bleeding of unknown cause, so that's the number of people who are affected, is unknown. However, individuals with bleeding of unknown cause usually make up more than 10% of clinic patients in the HTCs. So in Calgary, for example, about 12% of our bleeding disorders patients actually are diagnosed as bleeding of unknown cause. According to the literature, and we see it in clinical practice as well, actually, and for me, over the past 8 years that I've been at the clinic, we've been seeing increasing numbers of people diagnosed with bleeding of unknown cause. And this is particularly true for those individuals who are referred to us for heavy menstrual bleeding and or postpartum hemorrhage. These are all taken from the study down below from 2019. Most commonly, we see individuals who are female, so between 60 and 91% of individuals referred to clinic before this diagnosis are female. They tend to be relatively older, so mid to late 30s. And these tend to also be individuals with high bleeding scores, so not just positive scores or those scores that are above the cutoff, but high scores. And so one note before we go on about bleeding scores is that there are 2 tools that can be used, and both have slightly different cutoffs for what's considered to be a positive score. Regardless though of which score is used, individuals with bleeding of unknown cause actually have higher bleeding scores at the time of referral, not only from normal individuals or unaffected individuals, but also higher than those people with confirmed bleeding disorders like von Willebrand's disease or other diagnosed platelet function disorders. The other characteristic that's not on the slide that we see in individuals with bleeding of unknown cause is a family bleeding history. So about kind of 30 to 40% of individuals have first or second degree relatives with bleeding symptoms. So this table is actually from a 2007 study, but it continues to be what we see in practice and definitely what we see here in the clinic in Calgary. So in this particular study, 88% of females were referred due to menorrhagia and usually an associated iron deficiency. So we certainly see this in the clinic. And in my experience, postpartum hemorrhage is actually a common referral reason as well. In this study here, it was only about 65%. Other symptoms like bruising, epistaxis, surgical bleeding are common amongst both males and females with this diagnosis. However, in my experience, I've just noticed over the past little while an increase in the number of women being referred to the clinic for ongoing or abnormal bleeding or oozing, or even delayed wound healing following surgery. So these are two quotes from a patient in the clinic that she shared with me, and I thought they captured very well her experience for sure. So she said, "I started to bleed when I was 9 and was passed from specialist to specialist. And then diagnosis for her wasn't until my children started bleeding." When we talk about diagnosis, there really are no standard diagnostic criteria for bleeding of unknown cause. This really is a diagnosis of exclusion. The only positive check mark is bleeding. So this actually makes the bleeding score a really key part of the assessment. So in females with bleeding of unknown cause, mucocutaneous bleeding is quite common. So if we think back to our case, Jane, from the beginning, she describes having menorrhagia, postpartum hemorrhage, and bleeding from small wounds. A detailed family history is super important. You need to go through all first and second degree relatives, or as many as you can. We get referrals from the Children's Hospital here in Calgary fairly regularly, actually, for moms who have similar symptoms to their children. Medications and supplements are also important to know, as some can contribute to bleeding symptoms due to their effect on how the platelets work. So a really common medication is NSAIDs, so like ibuprofen. It's also really important to do a physical exam for non-trauma bruising or bruising on those unexposed sites. So one of my patients said, how did I get that? Or where did that come from? Those types of bruising. So in Calgary, to further characterize mucocutaneous bleeding disorders, we use a Baton score. And a positive Baton score actually indicates hypermobility. A study that was done actually here by the Calgary group in 2013 found that a positive Baton score was associated with increased odds of an underlying mucocutaneous bleeding disorder. And so that has been incorporated into our assessment of bleeding of unknown cause. There's a theme here. Just like there's no diagnostic criteria, like standardized criteria, there are no standardized pathways or algorithms to follow for laboratory or diagnostic testing. This is partly because we really aren't sure what causes or contributes to the bleeding seen in individuals with bleeding of unknown cause. And in many cases, we just really haven't figured out how to measure the changes that have occurred and how to identify the issues specifically. In the literature, though, there is a common set of steps that the specialists will work through and we work through in the clinic. So essentially what we're doing again is testing for and eliminating diagnoses such as von Willebrand's disease, other super rare factor deficiencies, platelet disorders, etc. The thing to remember is that because some of these tests are affected by stress, medication, supplements, even the testing substrates at the bottom of the lab tubes, they're usually done twice just to be really certain of what we're getting. If you remember way back to the beginning, again, for Jane Doe, her von Willebrand levels were normal on 3 occasions, and that's just to simply rule out that diagnosis. We do CBC and tests such as an INR, which is a test of clotting, to look for other concerns, again, to rule them out. So things like anemia and iron deficiency. We do blood typing to identify individuals with blood type O, because we do know that type O blood is a risk factor, not only for bleeding symptoms, but also for increased bleeding and severity of bleeding in individuals with most bleeding disorders. There is a note on the slide about third line tests. These are the things like the tests that look at how strong the clot is once it's made. To date, though, they really haven't been great at detecting any kind of abnormalities and are mostly used in research. If we go back to Jane, when those wisdom teeth that she had out needed to be extracted, the dentist initially canceled, which I'm sure sounds familiar to a lot of people, and then we canceled because of the diagnosis. What ended up happening was that education was done by the clinic and the surgery was rescheduled. The treatment plan for Jane was DDAVP and tranexamic acid, It went well, a little bit of extra oozing for 24 hours after the wisdom teeth were initially pulled. And that was resolved with actually tranexamic acid paste, so crushing up the pill and putting it directly on the extraction sites, which is something we do a lot. When we talk about management of individuals with bleeding of unknown cause, again, there's really minimal guidance on how best to manage and prevent bleeding in these individuals. Part of the challenge is that there really is nothing objective to measure. So for example, if we want to see if DDAVP will work for patients with von Willebrand's disease, we can measure before DDAVP levels and after DDAVP levels. But in individuals with bleeding of unknown cause, those levels are normal to start with. Everything we can measure is normal at the beginning. So what ends up happening is we give it and we watch and look for bleeding or no bleeding and make our assessment of effectiveness based on that. We do use both tranexamic acid and DDAVP together for the prevention and treatment of bleeding and bleeding of unknown cause. And we use it for things like menorrhagia, postpartum bleeding, post-dental extraction, nosebleeds, that type of thing. It really does seem to be effective, at least that's what we've noticed here in Calgary. And really most of the time, there are no unexpected or abnormal bleeding events or things to be concerned about. What we do happen sometimes is that we need to use platelets, and they may be considered for more invasive procedures or for those people who have really high bleeding scores. So kind of super high, kind of in the 20s. And so ultimately, though, really we're looking at personalized treatment plans and the decision regarding which treatment to use. So whether we go with DDAVP and tranexamic acid or whether we have to use platelets is highly dependent on the individual's past bleeding history and what the actual surgery or procedure is that they're getting done. So another quote, a couple of quotes from patients. Sometimes you take risks, even though you shouldn't, because you're so tired and embarrassed of explaining. And you learn to take care of yourself, because if you go to the emergency department and they see undefined bleeding disorder, I don't want to sit and explain. So really, one of the challenges with bleeding of unknown cause is a lack of distinct bleeding symptoms. There is some thought that there may be more mucosal bleeding in individuals with unknown cause compared to other disorders, but the symptoms really are essentially the same as those of other mild to moderate bleeding disorders, including like mild or moderate von Willebrand's disease and those mild platelet disorders. This really is important to note because what it means is that we manage all of these individuals in the same way. So it doesn't matter what the underlying diagnosis is, the management is the same. Most individuals with a family history of bleeding don't actually have a family diagnosis when you're talking about individuals with bleeding of unknown cause. So instead, what happens is you hear, well, mom bled like me, my grandmother bled like me, my aunts all bled like me. And what they have is almost a normalization of bleeding symptoms. And so one of the challenges with bleeding of unknown cause is when these people and when these individuals learn that this is actually not normal bleeding, it can be a bit shocking and a bit unexpected. The other thing to consider is that family planning and counseling, there's no genetics. So there's no way to tell who will be affected for women of childbearing age or people looking to expand their family. There's very limited counseling that can be done in terms of prediction. These are just a few of kind of the pros and cons of a diagnosis of bleeding of unknown cause. One of the pros, especially here in Canada, is you can be registered in an HTC. You have access to experts. There's personalized treatment plans, and there's family counseling, such as it is, but also that monitoring and those referrals as needed. There are, of course, insurance implications for a diagnosis, anxiety and guilt and blame regarding inheritance, especially around that lack of predictability of what will happen with children. Concern around bleeding risk in sports and lifestyle. Do you have to change what you're doing now that you know that you have this diagnosis? And then again, that lack of definitive diagnosis, and we saw that in one of the quotes around showing up at Emerge for treatment and not really having a firm diagnosis. Thank you very much. And I'd like to thank T especially for sharing her experience with me and allowing me to share it today. And those are my references.